Hello and welcome to People for PrEP, Identifying Barriers to HIV Prevention. I'm your moderator, Rachel Deer with DKB Med. Thank you for joining us. We're excited to bring you this very important webinar today on the topic of PrEP. We've got both clinicians and community members. At the conclusion, you'll be able to access the evaluation to claim your CME and CE credit. Your thoughts and comments are important and will help us develop activities on this and future topics. So let's kick it off. We're so excited to welcome our expert presenters, Dr. Quinton Robinson, Dr. Augustina Beringer, Melinda Pippick, and a special welcome to our panelists, Deja, Blossom, Patris, and Matt. Welcome, everyone.
Good evening, everyone. I'm Dr. Quinton Robinson. I'm an infectious diseases physician in Atlanta, Georgia.
Hello, everyone. My name is Augustina Beringer. I am a PA and have a doctorate in global health and disaster medicine. I'm the Chief Medical Officer for Heart to Heart International, a healthcare NGO based out of Kansas City, Missouri.
Hi, my name is Melinda Pippick. I'm a nurse practitioner. I currently practice in primary care at a federally qualified health center in the south side of Chicago called TCA Health. In my past role for about 5 years, I worked in retail health and sat on the corporate-wide sexual health peer mentor panel for that retail setting.
Hi everyone, my name is Deja Cabrera. My pronouns are she, her, hers. I am from San Diego, but I'm currently in Florida. So yeah, there's that. I am transgender. I work at the San Diego LGBT Community Center, where I am the community health educator and advocate, and I am also a trans woman on PrEP.
Hi, everyone. I am Coach Blossom C. Brown. I'm a prep retention navigator here in the great city of Los Angeles, California. I have been doing this work for many years. My pronouns are she, her, hers, and super grateful to be here.
Hello, I'm Patris Scobia. I'm from Baltimore, Maryland, and I'm currently taking PrEP.
Hi, I'm Matt. I live in New York City. I'm queer. I'm 23, and I've been on PrEP since I was 18.
Thank you so much, everyone. Here are the disclosures. This educational activity is supported by an independent medical education grant from Gilead Sciences. However, all activity content and materials have been developed solely by the planning committee members and faculty presenters. And here are the learning objectives. Identify barriers to HIV prevention among cis and transgender women and among young people. Describe the impact of stigma on the mental health of people who are LGBTQ+, and discuss strategies to overcome barriers, specifically stigma, that lead to undertreatment and poor outcomes for at-risk populations. I'll now turn the presentation over to Dr. Robinson.
All right, let's get started. So as we set the background and kind of the baseline for tonight's conversation, we're just kind of look at the HIV epidemiology in the US. So overall, new diagnoses since 2008 has been on a gradual decline from about 43,000 to now 36,000 cases annually. However, when we look at the demographic groups that are most affected in terms of new diagnoses, most of those new diagnoses are occurring through sexual contact, primarily through male-to-male sexual contact, but heterosexual contact is also a method of transmission. And when we look at how these new HIV diagnoses are broken down by both race and ethnicity, we do see that the majority of new infections are occurring in the age group 25 to 34, but there are some significant increases in the age group 13 to 24. And based upon race and ethnicity, we definitely see that the majority of the new HIV diagnoses are occurring in African Americans, with Hispanic and Latino populations following. So when we talk about HIV, we also can't miss the opportunity to talk about STI. So the STI surveillance data from 2020 indicated that there were about 2.4 million cases of STIs reported in 2020. And of the STIs that we're looking at, gonorrhea, chlamydia, syphilis, all of them except for chlamydia have had significant increases since 2016. Of note, congenital syphilis, those are babies being born with syphilis, has actually increased by 234% since 2016. So definitely looking at what our STI data looks like, there is an indication that people are still having sex even through the pandemic. All right, so now that we've kind of set kind of our background of what HIV looks like, let's talk about some specific groups of people who are at risk of exposure to HIV. So we're going to talk about cis and transgender women. So when we look at HIV diagnoses among cis and transgender women, they actually contribute about 21% of all new HIV diagnoses. And we see that the rate of HIV new diagnosis has been relatively flat in both of those groups. So when we talk about HIV diagnoses and the disproportionate effect of amongst women and transgender women, 21% of new HIV diagnoses actually occur in women, but however, women or those who identify as female are only 8% of PrEP users. So as we talk about this and we think about this through tonight's discussion, what are some of these barriers for cis and transgendered women? Some of these barriers include that women may be unaware that their sexual partners have other partners, use injection drugs, or may not be using other harm reduction measures such as knowing their STI status, the use of condoms for sex, safe needle exchange and syringe exchange. But even amongst women, behaviors that increase their exposure to HIV, women still have low rates of testing. And we'll talk about what some of those barriers to testing are. And then specifically within transgendered women who may have a particularly high exposure to HIV and report high HIV testing and PrEP awareness, PrEP usage is also low. And we'll talk about how the ideas of medical mistrust, transphobia, concerns about drug interactions, and just the overall lack of access to quality healthcare contribute to these barriers to PrEP. So let's talk about HIV amongst youth and young adults. Again, people aged 13 to 24 contribute about 21% to the rate of new HIV diagnoses overall, even though there's been, again, a gradual decline from 2012, the advent of PrEP, up until our most recent data in 2020, 2019. And again, looking at how PrEP is underprescribed to young people, again, young people account for about 21% of new HIV diagnoses, but they only account for 13% of PrEP users. So there's definitely an opportunity to have this conversation amongst young people. So what's contributing to some of these, this disparity or discrepancy between HIV diagnoses and PrEP utilization? Part of it is actually the lower health care use by LGBTQ plus youth. Looking at a survey of sexually active young adults, most of them did not get needed medical care in the last 12 months. There's actually a need for increased medical care for STIs, family planning and contraception, and conversations around substance use. And one of the primary reasons why we saw that LGBTQ plus youth were not accessing healthcare was that they didn't actually want their parents to know either about the type of healthcare that they were accessing or if there were conversations about their identity. So again, those conversations about identity kind of leads us to our next topic around stigma. But before we get into that, I kind of want to pull some of our community in. So Matt, can you talk about kind of your experience in terms of, briefly accessing healthcare as a young adult?
Well, so I first got on PrEP, like I said, when I was 18, which was 5 or 6 years ago. And that was when PrEP was still, it's still new to the market, but it was really new to the market then. And I was a senior in high school preparing to become sexually active, and I had heard about it from the internet. And I told my parents about it and went to my pediatrician. And I asked if I could go on this medication. And in doing that, it was kind of a funny trip to the doctor, because in doing that, I had to explain to my doctor that I was gay. And she was so sweet, but she reached out and took my hand and was like, "You're loved and I accept you." And I was like, "That's great, but that's not why I'm here. I'm here because I want this medication." And then she didn't know what PrEP was. So I ended up having to explain to my pediatrician what PrEP was so that I could get it prescribed.
So now we're talking about stigma as a barrier to healthcare. So as we start this conversation, I like to set these kind of background information. There's this intersection of HIV and some of our social determinants of health, poverty, access to healthcare, access to food insecurity. So looking at this map here, we see that in the darker blue, those are states where there are households that are below poverty level. And looking at this animation, you can see there's a similarity in the increases in new HIV diagnoses in those states that have higher households living under the poverty level. And so the South actually accounts for over 66% of new HIV diagnoses among Black individuals, and for 42% amongst Hispanic and Latinx individuals. So again, the majority of the Southern United States, like Georgia, where I am, a lot of households are below the poverty level, and those same states actually have the highest rate of new HIV diagnoses. So when we talk about HIV risk, and these are our populations that are significantly exposed to HIV, in the US, the overall lifetime risk of HIV is about a 1 in 20. Looking at white males, it's about 1 in 171. White females' overall lifetime risk of HIV is 1 in 874. But when we talk about those groups that are at highest risk, Black males overall, their overall lifetime risk is 1 in 27. Hispanic males, 1 in 50, and Black females are 1 in 75. And that's your overall lifetime risk if you do nothing to mitigate their exposure to HIV. So there's definitely some significant conversations to be had. So who's using PrEP? Again, looking at our map and our data, 42% of new HIV diagnoses occur in Black people, but the overwhelming percentage or the overwhelming majority of persons using PrEP are white. So what can we do to mitigate this disparity here? And how does stigma contribute to this? So just give you an idea of kind of setting where we are with stigma. Stigma is a social determinant that may be more readily immediately addressed by healthcare providers. Stigma exists in different settings. The lack of cultural humility or cultural competence contributes to stigma. And this then leads to denial or refusal of healthcare services. Verbal or physical abuse are experienced by sexual and gender minorities. So what we found in a survey of around 1,600 LGBTQ plus adults, 15% of them actually avoided medical care because of disrespect or discrimination. And looking at those groups of those within the LGBTQ community, the majority of the ones who are experiencing stigma tends to be those of trans experience, either avoiding preventive screenings, experienced discrimination for a doctor, or had to teach providers how to get the treatment that they needed. So how is stigma a barrier to healthcare? It impacts the individual's perception of their risk because of a stigmatized condition. It limits their willingness to seek HIV testing or prevention services. It affects their adherence and persistence to prescribed therapies. And then those barriers of stigma around HIV and sexual and gender identity can then be further emphasized because of racism and other stigmas such as substance use. So how does all of these ideas of stigma and these different ways people feel stigmatized affect their mental health? So talking to specifically Deja and Blossom, how has stigma within the healthcare setting affected your physical and mental health?
As a Black trans woman, it took a toll for sure. I couldn't go into certain spaces without feeling discriminated and feeling, oh wow, bringing back a lot of memories, but it took a toll on it, and I had to learn how to navigate, because as a trans woman, being in survival mode is kind of my thing. I've learned how to navigate in the survival mode, especially in the healthcare setting. And so, yeah, that was kind of a little bit of my experience.
As a Latin trans woman, the machismo that is in my community is stressful. You know, we're not allowed to show emotions. We're not allowed to cry, and, I think just the idea of being a man and the pressures of that, and then feeling the feelings that I'm feeling of being a woman and, being fish and femme and, living my best life, but also going into a society that does not see me as that yet, is hard and challenging. And when you go to these professionals that are supposed to help you, and they don't help you, or they look at you like you're weird, or they look at you like you're their next science project, it's like, okay, I guess I got to roll with the punches. So it's definitely difficult.
Thank you for that.
And Quentin, if I could jump in, I just want to
Sure.
also clarify that we're not just talking here about healthcare providers who are intentionally discriminatory or evil in any way, right? A lot of the experiences that our patients have that are less than pleasant and less than helpful, to say the least, are just out of ignorance. And so it is upon each of us to educate ourselves to serve the communities that we serve and to serve the patients that we take care of.
All right. Thank you. Thank you for that. So when we talk about mental health concerns within people who are within the LGBTQ community, they're more than twice likely to have a mental health disorder and more than 2.5 times more likely to experience some form of depression, anxiety, or substance use. Which is a very important point, 2.5 more times likely than the general community. And so how do these social determinants affect the health of our LGBTQ individuals? You know, the evident one is that there's a shortage of healthcare providers who are both knowledgeable and culturally competent in LGBTQ health, understanding the nuances of the communities in which they're taking care of people and working within those communities to understand language and customs that may be particular to those groups. So now that we've kind of talked about what HIV looks like in the United States, who's affected by it, what are some barriers that are existing between, you know, women, young adults, how all of that impacts people's overall mental health, let's talk about how we test and prevent HIV. So the first thing is, how do you ask the questions? You know, you can set the stage, you can use gender and sexual orientation neutral language. When you ask about how someone's having sex and who are their sexual partners, you don't necessarily have to say, hey, are you gay or straight? Do you have sex with men, women, or both? Use open-ended questions and be straightforward and sensitive. Like, tell me about your sex life. Who are you having sex with? How do you have sex? And allow the patient to kind of generate that natural flow and that show the patient that you are both comfortable and willing to listen, and make the patient comfortable enough to be sharing their details of their intimate life. So when we talk about the knowledge of HIV status in 2019, 13% of people with HIV do not know their status. Again, that's 13% of people who are living with HIV are not aware that they are living with HIV. But those rates are even higher for younger people. 44% of people between the ages of 13 and 24, and 24% of people between the ages of 25 and 34 are not aware of their HIV status. So that's definitely a conversation we should be having. And when you approach HIV testing, approach it from a status neutral care continuum, which is you start with an HIV test and you have 2 ways to go. The HIV test is negative, you have a conversation about prevention methods and PrEP, continued participation in care, you then reduce their risk of HIV and you repeat their HIV test. On the other side, you start with an HIV test. If that test is positive, you have a conversation about treatment, you get them linked to care, you keep them in care, and you maintain their viral suppression, and you again decrease the transmission and risk of HIV. Ongoing maintenance and support and engagement with the healthcare system is crucial in a patient, whether they have a positive or a negative HIV test result. So the current guidelines of HIV testing, who should we be testing and how should we be testing them? So the old thought of targeted testing based on risk categories, i.e. this person has sex with multiple partners or this person is having sex with a man without a condom, you'll still miss about 20% of people living with HIV. The United States Preventive Services Task Force gave the grade A recommendation of screening all adolescents and adults aged 15 to 65 at least once a year, or at least once in their lifetime for HIV. And then repeat screening is reasonable for people with potential increased exposures, sexually active adolescents and adults, and anyone who comes in asking for an STI test or an HIV test should get an HIV test. So specifically talking about screening for HIV, Laboratory-based testing is your standard method of testing. An antigen antibody test, if it is not a rapid test, you must bring the patient back for their results. Rapid tests are extremely advantageous. You get results within minutes, and then it increases your access to prevention and or intervention, i.e. linkage to healthcare services, and they're easy to administer, whether it's from a blood draw, from a finger prick, or even an oral swab in terms of HIV testing, which oral swabs have kind of fallen out of favor, but it's still a fantastic way of testing. But your HIV rapid test may miss recent or acute infections. So again, as clinicians and even as community, be aware of the signs and symptoms of acute HIV infection. If someone presents with a headache, fatigue, myalgia, sore throat, fever, or swollen lymph nodes, and has had a recent potential exposure to HIV, that's a perfect time to talk about alternative methods for HIV testing. So who needs to hear about PrEP? All sexually active adults and adolescents should be informed about PrEP, primarily because a lot of times patients don't disclose their sexual or substance abuse behaviors or increased risk behaviors for HIV to their healthcare providers.
Quentin, could I interject to the
Sure.
point of disclosing sexual behaviors and other behaviors to healthcare providers? This is where urgent care and convenient care things can go one of two ways. Either people don't know you, and so they're less comfortable disclosing things, and so you have to ask things in a very specific way. Or sometimes people feel more comfortable speaking to a provider that they may not see terribly regularly, that is not, as Matt mentioned, their pediatrician from their whole life, or especially for younger patients. I don't know your mom. I'm not going to tell your mom that, that you were asking these questions or that you were looking for these tests. So it's important, even if you're in a setting where you think, well, this is sort of like a one and done visit, it's important to address these things, because you never know. Patients have opened up to me with things that they've told me they don't feel comfortable sharing with their primary care provider. And then sometimes the opposite is, of course, as well the case.
All right, thank you. So when should you consider PrEP? When a first opportunity is when a patient requests PrEP, even without disclosing a specific risk. If someone comes in asking for PrEP, that is when you have a conversation. Other opportunities are when people come in for STI testing, or they presented to you with a request for frequent STI testing or treatment. If they ask about HIV testing, if they disclose to you that they have had multiple sexual partners, sexual activity in high prevalence areas, going back to our first conversation, where 66% of the new HIV diagnoses in the United States occur in the South. So if you're a healthcare provider in the South, you probably will want to have a conversation about PrEP with the majority of your individuals there. And the only contraindication, the only reason why you would not start someone on PrEP is if they are coming in with a new HIV diagnosis. And at that point, that's when you would link them to HIV care. So there really isn't a reason to not start someone on PrEP if they're interested in it. So PrEP effectiveness. So does really, taking a pill or getting an injection decrease your risk of getting HIV? The answer is yes. Oral PrEP reduces your risk of HIV acquisition from sexual exposure by over 99% when taken as prescribed. And it also reduces the risk of HIV amongst people who inject drugs by at least 74% when prescribed. However, it does not protect you against other STIs. So those conversations about syphilis, gonorrhea, and chlamydia and screening and testing must occur. So what are your options for PrEP? You've talked to someone about PrEP, they're interested in PrEP, you've done an HIV test, they're negative. What are your choices? So you actually have three options now. You have oral PrEP, which consists of Truvada or Descovy, which are branded drugs. Tenofovir TDF was the first drug approved for PrEP in 2012. Anybody with normal functioning kidneys, there is a small risk of kidney or bone toxicity with the drug, but it's approved for all at-risk populations, and there's generic forms available. The other drug is tenofovir alafenamide, or TAF, T-A-F. That was approved in 2019. and is actually approved in people who have somewhat compromised kidney function, and it remains effective. It has less bone and kidney toxicities. However, it's not indicated for people who are at risk of getting HIV through vaginal intercourse. There is, ongoing potentials for clinical trials looking at the use in those populations, and it's a smaller pill. Your third option is injectable PrEP, which is Apretude, which just got FDA approval this year, or cabotegravir. It's an injection that's done in the clinician's office every 2 months. Compared with oral PrEP, it has a 69% lower risk of HIV in cis men and trans women, and a 90% lower risk of HIV in cisgendered women. It's been approved for use in all populations. It has minimal drug interactions. Common side effects are injection site reactions and fatigue. They're really, are fantastic options for people. You have the conversation, they can choose oral or injectable PrEP. So can you initiate PrEP on the same day that you see someone? For Augustina and Melinda, in urgent care and convenient care settings, sometimes that's your perfect opportunity and you're not sure if you can engage this person to bring them back. So can you start someone on PrEP the same day? If you're interested in doing that, your clinic must be able to conduct point of care HIV testing. Ideally, get an HIV test and get the results back within that same day. Oral fluid should not be used in testing for rapid initiation. It must be a blood-based test. Draw blood for kidney function and additional HIV testing. If there's kidney dysfunction or there's a positive HIV test, you should be able to connect and follow up with them quickly. And then your clinic should be able to provide scheduled follow-up care, and contact with patients if labs indicate the need to discontinue. If you're unable to provide ongoing care, be aware of the resources in your community that are providing PrEP and link a patient to a provider who can.
Oh, just to interject that for 1 second, Quentin. On that same day PrEP, if you have a serum or a blood rapid test and you're in convenient care and you want to start same day PrEP, you have a pharmacist right next to you who is a great resource. So not only can you do the same day PrEP, you can consult with the pharmacist to make sure, okay, what do you have in stock? What can I give them today? What's in their insurance network? How do I get them the resources if they don't have insurance? So really utilize that pharmacist to help you get this off the ground.
Yeah, thank you for that. So now you've considered prescribing PrEP. How do you follow the patient? Like, what are your next steps? How hard is this to do? It really isn't difficult at all. If you've started someone on oral PrEP, you're going to see them every 3 months. And at those every 3-month visits, you're going to prescribe, you're going to take an HIV test, you're going to talk about signs and symptoms of acute HIV. You're going to ask them, are you taking your pills every day? How are you taking your pills? Are you missing any pills? You're going to screen them for bacterial STIs like syphilis, gonorrhea, and chlamydia. And you're going to test whatever parts of their body they use for sex. So we talk about 3-site testing, oral, rectal, urethral, or vaginal. And then other labs, you may consider checking their kidney function and their cholesterol. If you're considering injectable PrEP for someone, you're going to do the same things. You do it a little bit more frequently. You're going to see them every 2 months. Because there's no need to count pills or ask how many pills they're taking because they've had, a depot injection that lasts for 2 months, you don't necessarily have to assess for adherence. But the basic idea here is that you're going to see these patients frequently, and you're going to screen them for HIV and screen them for STIs and talk about their sex life every 2 to 3 months. So someone has a question about the long-term side effects because they don't like to prescribe medications unless there's a strong benefit. Here, I think we've demonstrated there is a strong benefit to decreasing someone's acquisition of getting HIV. So I think that's one, there is a strong benefit to prescribing a daily medication. However, these are medications that we have, at this point, years of experience with on the treatment side. So in terms of overall long-term side effects, there really isn't a big difference between oral PrEP and those who are using those same drugs for treatment of HIV. So there is some data about that. So now that you've screened someone, you've talked about PrEP, you've gotten them started, how do you get them drugs? Most insurance plans and state Medicaid programs and Medicare cover PrEP. A prior authorization may be required. Ready Set PrEP is a federal program that provides PrEP to people with no prescription drug coverage. For those who have commercial insurance, there is copay assistance, Gilead advancing access for oral PrEP, ViiV Connect for injectable PrEP. Some states have PrEP assistance programs, and your documentation status, whether you are a documented immigrant or not, is not a factor in your eligibility for PrEP.
That is some great information that is useful for our colleagues in many settings, including primary care offices, urgent care, convenient care, etc. As Melinda just said, not every person is close to a major metropolitan area, but most people in the country do have access to a health clinic inside a drugstore or a large grocery store. However, many of the people using these urgent and convenient care settings may not be seeing a primary care provider. So we have an opportunity there to test for HIV, discuss sexual health, and help protect our patients. We need to take advantage of those opportunities if we're going to slow the HIV epidemic by preventing HIV in people who have potential exposure. Now let's move on to our Meet the Patient segment. Deja, you know we've had a conversation about stigma and how it impacts healthcare. If you don't mind, could you talk a little bit about some of your personal experiences, including those that were perhaps less than positive?
Yeah, I think for me as a trans woman, gosh, there's the healthcare system. There's just so much to unpack, right? But in regards to my HIV status and inquiring about PrEP, the stigma was just placed on me that I was a sex worker. You know, being a trans woman, that must be my job. That must be the reason why I must want PrEP. And so kind of having a conversation of being a young professional, a young trans professional who is sexually liberated and also just wants to continue to take my own sexual health into my own hands. And, you know, if we take flu shots to prevent the flu, why not take something to prevent HIV? And earlier in the chat, I think there was someone that said, I personally don't want to prescribe meds with long-term side effects. And I think in the healthcare system, there's a lot of doctors who bring their personal beliefs into work. And when it comes to saving someone's life or someone else's identity or however someone else lives their lives, I think about just that, you know, being a trans person, the doctors telling me that they need to have a letter from a therapist or a psychiatrist for me to start hormones, you know, to start that whole process. So I think it's just, there's a lot of barriers already. So let's try to remove as many as possible.
Yeah, thank you for that. And so what's been your experience in having conversations in the trans community about the use of PrEP and gender affirming hormones? Because I know that a lot of times, as you know, the patients that I've seen and we've had the conversation, that concern comes up. And, you know, I know how I approach it, but how do you have that conversation within the community about the use of hormones and PrEP?
Yeah, so the girls know about PrEP. I feel like we've known about PrEP for a very, very long time. And I think the best thing would be if we were going to a provider that was providing our hormones and PrEP. I think what's hard is a lot of times we have to go to an infectious disease specialist, you know, and not our endocrinologist. And so having to tell our stories to multiple doctors is exhausting. And just like, you know, it's exhausting. So if we can go to one place where it's great, you know, and I think the girls are fine with taking it. We're not, it's a daily pill is not a problem. You know, if we take hormones every day, we can take another pill every day. If we're taking a blocker every day, you know, if we're doing injectables, doing the injectable, whatever. The conversation is not getting it is not the problem. I'm sorry, wanting it is not the problem, it's getting it.
I'd love to hear what have been good and bad experiences of how we providers what we do well and what we could do better.
Well, I don't really have any like negative, perspectives because I've never had a negative experience. But for me, it was just, as simple as I went for a regular checkup. They called me 2 days later and took down different STDs. And I mean STIs, not STDs. So they brought me back into the clinic and they had tested for everything. And I had to start the medicine and they had introduced me to PrEP because they told me that, I was more at risk for catching HIV because I was exposed to 2 different STIs.
And you felt like the encounter was respectful and addressed your situation, and people were obviously looking out for
with me, with my doctors and stuff, I'm pretty much like open.
Right.
So I never take it personal. So I've never had like a bad experience, I would say.
Matt, I know you mentioned earlier an experience that you had that was a little negative. Do you want to sort of build on that?
Yeah, I just I had to when I first sought out PrEP, my doctor, my pediatrician at the time didn't know what PrEP was. So I had to explain to them like what little information I had from the internet, and then just kind of hoped that she would prescribe it to me. And it wasn't until I moved to New York City for school that I was able to unite with a primary care provider who knew how to ask some of the right questions. I think he was also gay, which helped in the know too. But the issue there that I reflected on a lot was that a lot of young people aren't able to move to like metropolitan busy areas with doctors who are in the know about particularly queer sexual health. And they don't live in these places. And so it's felt unfair to me that, I was able to get this great doctor, but should I have lived essentially anywhere else in the country, it would be a toss up of whether or not I could get access to PrEP because my doctor probably wouldn't even know what it was.
So Matt, that really gels really well with the convenient care setting, because if you don't live in, a big community or metropolitan area, you will live in the area of a CVS or a Kroger or a Walgreens or somebody who has a retail health clinic. And that's where those providers need to be comfortable having the conversation about what is PrEP, being comfortable, asking about testing, and launching that care from there.
Interesting thoughts and comments for sure. Let's move on to our Q&A. How do you recommend engaging and encouraging young people ages 13 to 24 to take PrEP?
One thing I'd stress that's really, really important when you're talking to younger patients about sex who are thinking about getting on PrEP, especially if they're queer, is you want to put an emphasis on being non-judgmental about the questions that you ask and even just your tone when you ask those questions, because talking, in my experience, being asked questions about my sexual practices when I've only had sex a few times and I never had any sexual education that could apply to me as a queer person. And I just becoming a sexual person as a whole was something I and most queer people do on their own, learning things through the internet, learning things through porn. So this is all to say, we have at age, 18, 19, 20, pretty not super developed sense of our own sexual lives. And so, in my experience, like having a doctor jump out the gate and ask me if I'm a top or a bottom was like a little bit of like a whoa, like, okay, like, it's I would say approach those things gently. And I know, because you're all adults, obviously it can be hard to relate to a very young person who's just starting, their sexual journey, but tread lightly to get the answers that you need, I would say.
I'll share my youngest patient that I had on PrEP was 15, and he was referred to me. His mom used to work in the ER with me, so that was great. Yeah, I didn't meet him and say, hi, are you a top or a bottom? But I also didn't say, hello, I am Dr. Beringer. Do you practice anal insertive or anal receptive sex? Because he didn't know what that, it's like, lady, what's up with the big words? Talk to me like a person. So we got to know each other a little bit. And then Matt, to your point, right? It's like, I'm not assaulting a 15-year-old with a bunch of really invasive questions. Take time to develop that rapport. If you're new to prescribing PrEP or to working in sexual health at all, just make your appointments a little bit longer, because I know we're under a lot of stress to see more patients and quickly and move them along. But you're talking to people about stuff that's really intimate. And so when you do, especially with young people, when you get that comfortability, then use like normal person language. Don't go into like medical provider robot mode.
Is PrEP approved for women?
The first drug that was available for PrEP, TDF, was approved for use in both men and women. The newer form that came out, TAF, was only approved for use in men and transgendered women. And the injectable PrEP is for use in all. So at this point, of the options that we have, PrEP is available for everyone. So it's not a matter of commonly being used. Females, as in the question, and women in general, were always considered within the group of people eligible for PrEP.
How should you approach HIV testing for women in practice?
So in my practice, testing for HIV is right along with testing for every other STI. If you're testing for gonorrhea, for chlamydia, for trick, you're testing for HIV and syphilis as well. And I think that some of the barriers, though, is that providers might think that, because of women's transition, maybe rate is lower, maybe I don't have to worry about that. And that's what we're here to tell you, is that everyone needs to be screened for HIV, and everyone needs to have the conversation about PrEP, no matter what your setting is.
My previous practice, where I started an HIV prevention program, was in an urgent care setting, so not dissimilar to convenient care where Melinda practices. And so, people come not for routine primary care. And so, as Melinda mentioned, same for us. Anybody who comes in requesting STI screening for any STI we're going to have a conversation about HIV testing, right? Because if you have a risk that is concerning you about any STI, that means you also have a risk for HIV, and that naturally also opens the door to discussing PrEP.
Do you encounter resistance when offering an HIV test to a woman?
I have not outright experienced resistance to testing, but I will say that among the younger generation, there certainly isn't that fear of HIV that my generation, for example, had when in my college days in the 90s, early 90s, the HIV epidemic was causing terror amongst anybody who was sexually active. And I don't see that as much right now, which is wonderful. And it's a testament to the advances in treatment of HIV, but it can sometimes mean that people don't think about it as much. And so when I mention PrEP, that's where sometimes I encounter the resistance, like, whoa, you may be overreacting. I don't know, do I need that? Is this such a big deal? And the answer is yes, of course it's a big deal and you don't want to have it. So, so not so much to the testing, but sometimes people are surprised by mentioning PrEP.
What is 211 PrEP?
It's 211. So it's what we call on-demand or event-driven PrEP or intermittent PrEP for people who are sexually active. So if you've planned sexual activity or you're infrequently sexually active, it's an opportunity where you can take 2 doses of oral PrEP, specifically generic TDF, a day before yours, 2 to 24 hours before sexual activity, 48 hours after, then another 48 hours after. It's one of those things where it's a very nuanced conversation that we wouldn't have had enough time to put it in there, but on-demand and intermittent PrEP is definitely an option for those who are less sexually active.
Is it difficult to get insurance coverage for injectable PrEP?
It's a matter of just, looking at those things in terms of for the patient, whether there's difficulty with adherence, whether they're missing doses, or, I use, whether they have an unpredictable lifestyle and things like that. So just kind of having creative options.
Do you ever use a PrEP screening tool?
When I started our PrEP program in urgent care, we also started with a questionnaire because, again, it's just being sensitive to the fact that here you are for a fairly brief appointment. You've never met me, and now I'm asking what body parts do you use to have sex? And sometimes you're like, whoa, lady. Sometimes starting out with a questionnaire that patients can fill out ahead of time. You can email it to them. You're going to have the office email it to them, or they can do it in the waiting room if there's enough time. It just sort of feels a little bit less awkward for some patients to just answer it on paper, and it can open up those conversations.
What happens after someone has a high-risk exposure to HIV, such as when a condom breaks?
The condom broke. When I worked in emergency medicine, unfortunately, lots of sexual assault victims. That is a time for PrEP. So that is post-exposure prophylaxis, also sometimes referred to as NPEP if it's non-occupational. So it's not a needle stick, it's a sexual encounter. So very, very important to know that you need 2 different medications for PEP, 1 medication for PrEP. So because this person, especially if the condom broke a couple of days ago, could still be falsely negative on your even the 4th generation tests, that would be somebody that I would start on the 2, I always say 2 drugs, but it's actually 2 medications because one of them has 2 drugs. So 2 medications, 3 drugs regimen. So it would be the FTC product with raltegravir, and then bring them back in a month. Once they complete a 28-day post-exposure prophylaxis, bring them back in a month. At that point, you're going to test them again for HIV. At that point, they should have seroconverted if they were going to, but hopefully with the medications you gave them, they won't. And then you can convert them to PrEP with just the 1 medication, whether oral, where there's 2 alternatives, or the injectable, if they are somebody that is interested in doing that and that, has, if they're sexually active, they certainly may have some concerns about ongoing.
How easy is it to prescribe PrEP in primary care?
I worked in an area that saw visits for STIs all the time, all day, every day. People were coming to get tested for STIs. And I had patients ask me, do you prescribe PrEP? And I was like, no, that should be your primary care. It just sounds really complicated. HIV treatment, it just always sounds a little bit scary. And then people kept asking, and they were like, my primary care doesn't do it, or I have to go, travel an hour to a specialty clinic to do this. So I started looking into it, and I'm like, wait, this has to be really difficult, right? And it's not. It's easy. It's lower risk than many other things that we prescribe every day, including antibiotics. And the information is out there. We set up a very simple program, as Quentin had mentioned on one of the slides, bring them back. At the time that I started this, there was no injectable PrEP. So we just did the first one. And then when the other drug came out for oral, we did those 2, just bring them back every 3 months. Very important to do 3-site bacterial STI testing. So if any body part they use for sex, you're going to swab, or they can self-swab. You don't need to do the swabbing. And then check their renal function, because for oral PrEP, there is some limitations with that, and put them on PrEP. It's really that simple. The side effects, of course, every medication has side effects, but guess what? If they get HIV, they're going to be on more medications every day. So the benefits are astounding. And I just imagine a world where we all prescribe PrEP and we get rid of the HIV issue. Can you imagine that? That would be the absolute game changer in public health, right?
What are the contraindications to PrEP?
Literally the only contraindication to taking PrEP is if you have HIV infection. And the reason for that is because the drugs in PrEP are not a sufficient enough regimen to treat HIV. So you are risking having the patient develop a drug-resistant form of the virus, right? Because you're sort of partially treating it, but not fully. So it would be like giving somebody half a course of antibiotics. You wouldn't want to do that.
How is stigma manifested in practice?
I remember Truvada Horde kind of being one of the things that people would say a lot, because when we started first doing PrEP and when it started rolling out, people really did not understand what PrEP was, and they only just alluded it to gay men being able to access PrEP because they're very promiscuous, and having to debunk that has taken a lot of work. And so it was very stigmatizing for a lot of gay men that I worked with. But when I first started doing PrEP, I used to hear that a lot. And I used to hear clients come and tell me, oh, you should be having sex with women anyways if you want to get on PrEP. Like, why are you trying to get on PrEP? You know, you should be having straight sex. And I heard a lot of demeaning things that my clients have come and told me. And so that's why they look more for an LGBTQ friendly space to be able to access PrEP, because in these very conservative or I'm trying to find the right word, but in those other spaces, they're not really culturally competent and do not want to be culturally competent.
How can patient confidentiality be maintained, especially for young patients?
There are ways where you can get an explanation of benefits that don't actually have the services listed, especially in states where they're trying to, we have 18-year-old, 17-year-old on there, where the state says we can see you without your parents at age 12 or 14, then we have to bill the insurance. There are ways that the bill can be sent without the itemized list of services, I believe.
Also, in the state of California, our state program that does with PrEP, we have something called PrEP AP Confidential. So any client that's on their parents' insurance, they can actually go through the state program, get their medication paid for, get their labs paid for, and their parents not actually know.
Have the CDC guidelines changed, and do they now call for doing HIV viral load testing?
It's true. The current guidelines do recommend doing viral loads on PrEP patients in addition to fourth generation testing. That is a new recommendation in the guideline. It's primarily coming out of the data looking at injectable PrEP, where there were a few missed cases where people had gotten an injection, but they also had really early HIV infection that was before antigen developed and before antibody developed. So anything that will decrease the potential of giving someone with HIV a preventive medicine and linking them to care as an option. You can do both a blood-based viral load. If you're looking at kidney function, if you're drawing a tube for an RPR, you can add a RNA, a PCR to that as well, and do your fourth generation as well. So it is just an additional layer of screening patients appropriately and making sure that they're HIV negative. I don't perceive that as a barrier to access to PrEP, but I think that's a great point to bring out because that is in the guidelines.
What's the difference between PrEP and PEP?
PEP and PrEP, right? There's a big difference. So if somebody had a recent exposure and you're concerned that they may have just gotten HIV or been exposed to it, now is not the time for PrEP. Now it's time for PEP, for post-exposure prophylaxis, which is a 3-drug or 2 medication regimen. That's where that second medication comes in to avoid the risk of developing a resistant strain. And then that is a 28-day course. You bring them back, you test them again. Hopefully you did everything with your drugs that they did what they needed to do with the drugs and they didn't seroconvert. And then you can convert them or switch them to PrEP, which is 1 drug orally every day, or the injection every couple of months, every 2 months.
What are the PrEP requirements for people under the age of 18?
If you're doing PrEP, really for a 14-year-old, it's the same guidelines. You just have to make sure that they weigh more than 35 kilograms. Most 14-year-olds do. That's it. And the question about do you need parental consent, it depends on where you live. If your state says that they can't be seen for sexual issues and they're 16, until 16 or up, then you ask to need parental consent. If you're in Illinois and I think it's 12, then you're fine. So the parental consent goes by what state you live in.
Yes, when I was practicing in Massachusetts, anybody, I believe it was age 13, could have been 14 or over, could make their own decisions about sexual reproductive health, except for surgery, surgical sterilization, or abortion. And so not only did we not need parental consent for those patients, but there's also an act that states that health insurance that is under a parent or another, guardian, does not need to list in the explanation of benefit what the patient saw you for if it's regarding matters of sexual and reproductive health. So that 14-year-old's parent is not going or shouldn't get an explanation of benefit that says they saw Dr. Collins for PEP or PrEP or STI testing. It should just say the visit.
How long after exposure can PEP be given?
So someone has been potentially exposed to HIV, there's a 72-hour window for post-exposure prophylaxis.
What about PrEP in older people?
I use it as the other little blue pill. I had an issue where a patient who lived in a high rise, he was 65 years old. He came in with an STI of gonorrhea. And I proactively had a conversation about PrEP with someone who, came in with an STI. The other thing was I had a conversation with another primary care provider who says, I primarily see geriatric patients. They're not having sex. I was like, well, have you ever written a prescription for Viagra for any of your male patients? He was like, of course I have. Then I was like, then you should have a conversation with them about PrEP. So you're exactly right. We definitely don't want to forget our geriatric population because they are extremely active. And that's another group you can talk about using PrEP in.
How long does it take after starting PrEP to have protection from HIV?
In terms of when to start and how long do you have to be on to be protected? The data vary, and it varies between what type of sexual activity you are involved in. So the general consensus is that we usually tell patients somewhere between 7 to 14 days of daily PrEP, you will be at a point where you would be decreasing your risk of acquiring HIV.
What about missing a dose?
Women do not have much grace as men when it comes to missing doses. Men usually, what I tell my male clients is they have about 3 days that they could miss before they have to start over, and that protection builds back up within those 7 days. But with women, they have at least about 2 weeks, if I'm not mistaken, where it has to build up in the vaginal wall.
For women having vaginal intercourse, it does take a little bit longer to build the levels in the vaginal tissue.
Can PrEP be prescribed through telehealth, or do patients fall through the cracks?
Amidst the COVID pandemic, a lot of online and teleprep services became available. I actually don't think that patients are actually falling through the cracks that they're utilizing those services, and those services are being administered appropriately. Thank you so much. Thank you, everyone. Thank you to Augustina, Melinda, Blossom, Deja, Matt, Patras, Rachel, everyone, and all the participants. Thank you again. Hopefully we all walked away with something. All right, I'm gonna turn it back over to Rachel to close us out.
Great questions. Leslie, Dr. Robinson, Dr. Beringer, Melinda, Deja, Blossom, Patras, and Matt, thank you all for a terrific presentation.